End-of-life care. At the end of this presentation, the student should be able to discuss the importance of planning for end of life for everyone, discuss approaches to sharing bad news, identify important end of life legal healthcare decisions, provide holistic care for the patient and family or caregivers, differentiate between palliative and end of life care, describe options for where end of the life care can be provided, develop a plan for assisting patient and family or caregivers to meet physical, emotional, mental, and spiritual needs, and provide resources for the patient and family or caregivers. What is end-of-life care? It is the support and medical care given during the time surrounding the death of a patient. It may extend over days, weeks, and even months before death. Many decisions can and should be made much earlier in life because accidents, injuries, and acute life-threatening illnesses don't give advanced warnings. This also should include support of patients as well as their caregivers. When it comes to delivering the bad news, most education programs for healthcare providers focus on knowledge and diagnostic skills, with less emphasis on communication skills. Delivering serious bad or life-altering news is difficult for most providers. Principles to remember when delivering bad news: be professional, communicate caring, arrange not to be interrupted while talking with the patient, find out if the patient is there alone or if someone is with them, and if the patient wants them to be present. Patients prefer to receive such news in person with the full attention of the person sharing the news. Use clear, easy to understand language and allow enough time for questions. Realize that the amount of information the patient wants to know, especially when first given the news, varies by education level, age, gender, culture, and previous life experiences. Ask questions to help guide the conversation with the patient as well. Be honest and cautious about being overly optimistic. Be aware that sometimes the patient may blame the healthcare provider, which may cause a lot of emotion, and they may react with denial. Do not react to negative feelings directed toward you. Emphasize that resources are available to help provide support and provide an initial plan of action. Offer to meet with family members or others important to the patient. It may be very difficult for the patient to tell others. Involve the patient, significant other, and family members in planning care. Important decisions to be made. Healthcare providers should provide this information to patient and family if necessary. Decisions are preferably made by the patient when he or she is cognitively able to make these decisions. Many sources recommend that anyone 18 years of age or older should have the appropriate documents in place. In many cases, death is unexpected. These kind of documents may include advance directives, living wills, and other important documents. 5 important legal documents include power of attorney, durable power of attorney, a living will or advance directive, a living trust, if appropriate, and a will. Decisions can be changed at any time while the patient is still competent. A power of attorney is a document where a patient authorizes someone to make legal and financial decisions on his or her behalf only when the patient is no longer competent to do so or deceased. A durable power of attorney, also known as a healthcare proxy, is a document where a patient authorizes someone to make all decisions regarding healthcare, including choosing healthcare providers, medical treatment, and end-of-life decisions. This only goes into effect when the patient is no longer able to make these decisions. Decisions a healthcare proxy can make include choices about medical care, including medical tests, medicine, or surgery, the right to request or decline life support treatments, choices about pain management, including authorization or refusal of medication or procedures, admission to an assisted living facility, hospital, hospice, or nursing home, choices about where to seek medical treatment, including the right to move patient to another facility, hospital, or state, the right to see and approve release of patient's medical records, the option to take legal action on patient's behalf in order to advocate for patient's health care rights and wishes, and the right to apply for Medicare, Medicaid, or other programs or insurance benefits on patient's behalf. A living will, also known as advance directive, is where a patient states in advance what kind of medical care they do or do not want to receive. A living will is an advance directive that guides the family and healthcare team through the medical treatment the patient wants to receive if unable to communicate his or her wishes. This document is considered legal as soon as the patient signs and a witness signs, if it is required by state. A living will goes into effect when you are no longer able to make your own decisions. The most common decisions included in a living will involve CPR, DNR, DNI, and artificial nutrition and hydration. How to make a living will? The forms are available for each state at a number of websites. Requirements may vary from one state to another. The Alabama Advance Directive form is included in this module. The form is retained by a patient. Copies should be made and given to the healthcare providers as well. This slide demonstrates questions that appear on the Alabama Advance Directive form. Online forms for a will are available or can be done through an attorney. It's a legal document that states who will receive your property when you die, who will oversee your estate, and if you have children under 18, who will raise and care for your children. If you don't create a will, the courts will make these decisions for you. Dealing with financial affairs for someone who has died is very difficult if someone was not given power of attorney to act for that individual. A will may relieve family stress, confusion, and disagreements. Other important personal documents may include full legal name, social security number, legal residence, date and place of birth, names and addresses of spouse and children, location of birth and death certificates, and certificates of marriage, divorce, citizenship and adoption, employers and dates of employment, education and military records, names and phone numbers of religious contacts, memberships in groups and awards received, names and phone numbers of close friends, relatives, doctors, lawyers, and financial advisors, medications taken regularly, and location of living will and other legal documents. Important financial documents include sources of income and assets, Social Security and Medicare or Medicaid information, insurance information with policy numbers and agents' names and phone numbers, names of your banks and account numbers, investment, income, and stockbrokers' names and phone numbers, copy of most recent income tax return, location of most up-to-date will with an original signature, liabilities including property tax, mortgages and debts, location of original deed of trust for home, car title and registration, credit and debit card names and numbers, and location of any safe deposit boxes and keys. Providing holistic end-of-life care. views the patient as a whole within his or her environment, and realizes that a patient is made up of a body, mind, and spirit, and acknowledges the interdependence among one's biological, social, psychological, and spiritual aspects. Holistic care increases the depth of care providers' understanding of patients and their needs. It addresses mental, spiritual, and social needs of patients. It also involves significant others in the family in the plan of care. How are both palliative care and end-of-life care similar? They both focus on care to alleviate symptoms, pain, and stress of a serious illness, including breathing problems, skin irritation, digestive problems, fatigue, or temperature sensitivity. They emphasize on keeping the patient comfortable. It's appropriate for any patient of any age, and it can be received at home, assisted living facilities, long-term care facilities, or the hospital. And they both improve quality of life. The difference between palliative care and end-of-life care are as followed. End-of-life care does not include curative treatment that may be included with palliative care. Palliative care is provided as long as needed, possibly for years, to improve quality as well as quantity of life. Palliative care may transition to end-of-life care, often hospice care, if the healthcare provider believes the person is likely to die within 6 months. In the United States, people enrolled in Medicare can receive hospice care if their healthcare provider thinks they have less than 6 months to live, should the disease take its usual course. Costs of palliative care may be covered by insurance plans. In addition to sites previously listed, end-of-life care may be provided in an inpatient hospice facility. While caring for their loved one, caregivers may also become emotionally and physically drained. Let them know about support groups available in their local areas. It's not unusual for caregivers to die soon after the one they cared for due to the physical toll on them. They do need to mourn. They also need to allow themselves time to mourn. Avoid making major life change decisions for up to 6 months. Encourage caregivers to seek professional help for extreme depression, and also grief counseling is part of hospice services. The goals of end-of-life care are to maintain comfort of the patient, to maintain choices, to maintain quality of life of a person who is recognized to be dying, to support their individuality, and also to care for the psychosocial and spiritual needs of the patients as well as their families.